Welcome to the Silicon Valley Health Institute. We've been having lectures with top grade experts for the last couple of decades. And now we, we're doing weekly Zoom meetings because we can tap into talent all over the world. So we are a nonprofit organization. We will put all of our talks on our website, which is Silicon Valley Health Institute, SVHI.com, and join or donate as you feel. Anyway, today we have Filomena Trindade. She's a physician with master's in public health and internationally sought after speaker in functional medicine. She's a graduate of the fellowship in anti-aging, regenerative and functional medicine, and she teaches the fellowship program, which is a master's program through the University of South Florida, as well as the Institute of Functional Medicine. After obtaining her bachelor's degree in biology, she obtained a master's in public health, then went to medical school. She graduated first in her class in family practice from the University of California, Davis School of Medicine. She did her residency training in family practice at the UCSF Santa Rosa program. She's been in clinical practice for almost 20 years and has a functional medicine practice. She was a medical director of a nonprofit organization that catered to the underserved. She's currently very active in developing teaching programs in functional medicine in the USA, Latin America, and Europe. So welcome, Filomena.
Thanks, Susan. It's always a pleasure. So today I'm going to talk to you about reducing your diabetes risk. Really what I'm thinking I'm hoping I would leave you with is what things can I do to assess my risk, and also to have sort of a different perspective, because diabetes isn't that I have it or don't. It's not like diabetes type 1 when you're talking about diabetes type 2. It's in this continuum. You're insulin sensitive, then you become insulin resistant. You could stay insulin resistant, or you could progress to impaired glucose tolerance, prediabetes, or diabetes. But yet you can be suffering the consequences as if you had diabetes type 2, even if you're just impaired glucose tolerant or pre-diabetic or insulin resistant. So that's really my focus. And your New Year's resolution is to really assess, what are some of your symptoms, where are some of your risks, and what can you do about it? So I truly believe in having sort of a special place and balancing our right brain with our left brain, because we're going to be very, very left brain while I'm talking. So I want you to imagine a place that you love, or your favorite place, or your special place. This is mine. It's in the island of the Azores. It's Saint George is where I'm from. And that's where I've been living for the last 6 months. And before that, I would visit frequently. And Susan has joined me in one of my retreats. You'll see various pictures, and that's just my attempt to try and bring us back into the right brain just for a second so we can continue to listen and learn, because our brains can only really hold on to full attention and learning for about 20 minutes. So this is an area that's sort of world renowned for their cockles. It's the only place you can get them. And Anthony Bourdain did a cooking show there. And it's also a world famous surfing spot, as you can see, and it's one of my special places. I think the first thing that I think of when I'm trying to consider someone's risk is, how did this person develop insulin resistance, or what are their risk factors, or what are the triggers? Because we know it's not about our genetics only, it's about how does our environment interact with our genetics. And so in assessing our risk, we want to look at, do I have one of these? Do I have more than one? Because you can have more than one thing going on. But consider what happens with our gut microbiota, whether it's an imbalance like a dysbiosis, or it can also be an infection. It could be an inflammation in the gut microbiome due to eating wheat, for example, or gluten. But you also want to consider other food sensitivities, things that have been added to our food that shouldn't really be considered food. That would be your excess or food excesses, but also excess things in the sense of too much sugar, too much unhealthy fat, for instance. What about digestive insufficiencies, like not enough stomach acid, or exocrine pancreatic insufficiency, where your pancreas isn't working well enough? Oxidative stress, mitochondrial dysfunction, toxins, and then we can think of all the different types of toxins that can affect the pancreatic beta cell. Mitochondrial dysfunction I separate from oxidative stress, because you can have one necessarily without the other. Obesity. You know, when I was in medical school, I was told that the reason we had such high rates of type 2 diabetes was due to obesity. Well, now we know that's not true. It's most likely undiagnosed insulin resistance that is what causes the high rates of obesity that we're seeing in the United States. And unfortunately, most other countries are following our lead because most people are insulin resistant and they don't know it, because most traditional doctors are waiting for you to become pre-diabetic or diabetic, really diabetic, to do anything about it. But I want to convince you that it's all about the insulin, and it's really the insulin resistance. And the earlier you diagnose it, the easier it is to reverse. Do you know that just lack of sleep or being in a sort of sympathetic dominant stress mode can lead to insulin resistance, as well as other hormone imbalances? And in infections, you want to consider all the different types of infections, especially the occult ones, like your endodontal infections in your mouth, and the nutrient deficiencies, prescription drugs, prescription drugs you may be on currently, prescription drugs you may have been on in the past that could increase your risk for developing insulin resistance. And of course, we know that there are genetic predispositions or single nucleotide polymorphisms, but it's really all about that interaction with our environment. And of course, you can have more than one cause. So let's just focus now, and I'm going to show you some scientific support for why I created that list back in 2012. This was looking at the fact that a shift in our microbiota or microbiome, or the composition or the robustness of it, has coincided with an increase in diabetes type 2. And we know that many papers have alluded to the fact that the gut microbiota could be considered sort of that environmental factor that can modulate a lot of metabolic diseases, including diabetes and insulin resistance, as well as obesity. Sugar, right? The amount of sugar that we ingest, or I should say also the amount of sweeteners, because in the US in particular, it's also high fructose corn syrup, not just because of the corn syrup in itself, but also the fact that it can be laced with some heavy metals. And then gluten, you know, initially we had more studies looking at gluten in type 1. Now we also have it with respect to type 2. Heavy metals, things like arsenic, for instance. You know, eating a half a cup of white rice that's not organic per day can actually put you over the EPA limit for toxicity when it comes to arsenic. And, you know, a lot of cultures may have rice as sort of their baseline or ingest high amounts. So it's our job is to really educate people about what is too much, in a sense. We have studies looking at mercury as well as other heavy metals such as lead, for instance. And then I want to look at some of the endocrine disruptors, some of the other toxins that have been associated with insulin resistance. This is looking at phthalates, and phthalates are the chemicals that make plastic malleable. We think a lot about bisphenols, and actually bisphenol A is, as well as bisphenol S, and probably the others, but those two are the ones we have the most studies on, are probably that trigger for insulin resistance. But phthalates are also common in perfumes. So anything that is scented that has the word parfum, think of phthalate, and phthalate has been associated with damage to the pancreatic beta cell, which is what makes insulin, that then causes insulin resistance. Dioxin is another. And the biggest study on dioxin is the Cevesco Women's Health Study. So Cevesco is a city in Italy where there was an explosion in 1976, and there was the highest documented exposure to dioxin. And in 1996, they started a study of particularly the women that had been exposed. And what they found was there was a high correlation with dioxin to insulin resistance. And they wanted to know, well, which women were at the highest risk. And it was the women that were youngest at the time of the explosion in 1976, and also the ones that were closest to the explosion, so they had the highest exposure. It's really hard in medicine to prove cause, but in many cases, we're able to prove a correlation. And in this case, dioxin, there's a definite correlation with exposure and insulin resistance. And other sort of studies looking at endocrine disruptors or these persistent organic pollutants, we have looked at could there be a cause? And in PCBs, chronic exposure, we've actually been able to show that there is a causation with exposure to insulin resistance as well as hyperinsulinemia. And this was all independent of body weight changes. What about prescription drugs? I'm going to cover two main ones, the first one being statins, because now we have quite a few studies showing that statins can be that trigger that leads to diabetes type 2, and it can do it through several different pathways, some of which we understand better than others. It can increase oxidative stress. It can cause damage to the mitochondria, so it can cause mitochondrial dysfunction. But another way is that it can decrease adiponectin levels, and adiponectin is an adipokine that is very anti-inflammatory, probably one of the few adipokines made in the fat cell that's actually anti-inflammatory. Omeprazole is another, which is a protein pump. It's a PPI, or a proton pump inhibitor. I feel like sometimes it's prescribed like candy, unfortunately, because it's been used a lot for many gastrointestinal dysfunctions without really looking to see if that's exactly what was needed. So omeprazole is associated with a change in the gut microbiota, in the distal gut, and we know that it can cause or set the stage for bacterial overgrowth. It can also change the milieu of the gut microbiota and make you more likely to develop insulin resistance. And later on, I'll show you exactly what that pathway or that mechanism is. So my island is very long. It's called the Dragon, and very mountainous. And when the lava flowed, when the volcano erupted, my island was formed by 3 separate volcanic eruptions. So when it erupted and the lava flowed and hit the ocean floor, it formed certain flatter areas on both the north side and the south side of the island. And those are called phalanges. I showed you one, my first slide. This is another one where you can see there isn't as much sort of flat area, but these are beautiful areas that in some cases are summer homes and in other cases are year round. But it's also a great place that I really enjoy doing my hiking. Let's shift a little bit now into how exactly does the microbiota contribute to insulin resistance? What happens? There was many studies before this current one that I'm showing you, but it wasn't until this one was published in 2015 that you could really sort of understand the mechanism, because before that, there's been a lot of postulation, there's been a lot of controversy, but in 2015, this group actually looked at all the data and said, okay, these are the 3 mechanisms with the most literature support for how changes in the gut microbiome can lead to diabetes type 2. And it's pretty interesting because this is a European group that's actually pretty conservative, but for being such a conservative group and probably not knowing anything about functional medicine, they actually had a very functional approach, because they really talk about the different mechanisms, and the 3 with the most support are number 1 by LPS, or lipopolysaccharide. So we have bacteria in our gut, right? And we have a lot of gram-negative bacteria. The bacteria have cell walls, whereas our cells, human cells, have cell membranes. But we're constantly in changing, right? So as the bacteria die, the gram-negative bacteria die, the actual cell wall will lyse. And when it gets lysed, LPS, or lipopolysaccharide, is removed or released into circulation. Now, normally that is reabsorbed, that's taken up, that's degraded by our bodies without any difficulty. However, in the presence of a very high unhealthy fat diet, as what happens with the standard American diet or the horrible American diet, what happens is that we're not able to degrade the lipopolysaccharide. There's other things that affect it. And so the lipopolysaccharide lives around longer, and it binds to these receptors, are called toll-like receptor 4, and causes inflammation that can lead to insulin resistant diabetes. The other way LPS acts is that it can act directly on the pancreatic beta cell and cause inflammation. The only way the pancreatic beta cell knows how to respond is by increasing insulin production, which leads to a hyperinsulinemia, and it's that in itself that leads to insulin resistance. And I'll have a few more slides on that a little bit later. The second way in which changes in the gut microbiome can lead to insulin resistance. It's by short-chain fatty acids. So when we have a very robust and we have a normal milieu and an abundance of our gut microbiome, so the protective bacteria in our gut, our bacteria takes the fibers that we ingest, if we're ingesting sufficient fiber, and in this case, we're really talking about soluble fiber, and it will break them down into short-chain fatty acids. And it does three main ones: acetate, butyrate, and propionate. Butyrate is really special because it's the fuel for the colonocytes. It's also what helps create that mucin layer, that inner layer that protects our gut microbiota. However, when we're not ingesting sufficient fiber, is what happens in the US, unfortunately, and we have a low soluble fiber diet, then or we have changes in the gut microbiota, it's not able to make those short chain fatty acids. And so what happens is that in order for the bacteria to be fed, it actually starts to eat away at that mucin layer, and then you have no protection. The other way is by bile acids. So the gut microbiota is actually pretty amazing because it's responsible for also helping us digest and detoxify, as well as eliminate toxins. One of the things it does is it converts our primary bile acids into secondary bile acids. And primary bile acids are actually pretty inflammatory. So when you don't have the correct milieu, you're not able to form those secondary bile acids. And again, that leads to increase in inflammation. And it can also lead to inflammation in the pancreatic beta cell itself. So as I said, this study really sort of set the groundwork for what are the three most common mechanisms supported by science. But this was the part about this study that I thought was pretty amazing, because they actually said, well, how then do we affect the gut microbiota? How can we try and increase the robustness of our gut microbiome? And what has led to the changes in it? So very functional approach for a non-functional medicine group, so to speak. Well, so they talked about diet, the mode of birth, what medications you took, and were you breastfed or not, and what sort of extracurricular activities do you do? Do you smoke? Do you drink a lot of alcohol? What's your physical activity like? So they were really connecting the dots and trying to put it all together to say, okay, this is the outcome. This is what possibly could have led to your gut microbiome being what it is today. And so this was really interesting for me because what they concluded is they said, and I'm going to quote, one may envision that in the future, the effects of the minimal microbiota could be administered as a slow-released, encapsulated microbial cultures that could be tested in randomized clinical trials together with a healthy diet that's also rich in prebiotics, and that maybe that is the way to sort of look at the future. Now, the latest research in this area has really been also looking at the transplant microbe or gut microbiota transplants as a possible treatment for diabetes type 2. Not approved in the US as of yet. It's only approved for actually an infection in the gut, but in other countries, it has been approved and has been used mostly for your autoimmune and some of your neurodegenerative conditions. But just so that you know that there's a lot of information and a lot of research in this area. So next I want to think, okay, so where does insulin resistance start? And what do we do to that person? What happens first to that person with dysfunctional insulin signaling? Because in knowing the mechanism and understanding what goes on, that's where we can intervene. That's where we know how we best intervene, because there is a cure for diabetes type 2, but it's early diagnosis and aggressive treatment. And aggressive treatment looking at all the different causes, having this multifactorial or this functional approach, looking at what's the root cause and connecting the dots between the different things that have happened in that person's life that has brought them to where they are. I know that in conventional medicine terms, we can't say there's a cure, but there really is. The problem is that once you have a diagnosis in conventional medicine, then you can only say that that is controlled. So for example, if I have a patient, a diabetic type 2 patient that comes to me with a hemoglobin A1C out of control, 10.8, let's say, and we do my protocol and their hemoglobin A1C becomes 5.0 or 5.2, which is completely normal. It's not just in the range, it's absolutely normal. By all facts and purposes, that diabetes type 2 is reversed. They're cured, but I can't say that. I can only say that it's controlled because of the way ICD-10 codes are set up. So back to how did this happen? Well, when I was in medical school and residency, I was taught that it was all about adipocyte dysregulation, that it really was about having too many fat cells and there being this fat cell insulin resistance, that it started there. But that's really got me thinking that possibly I wasn't being told the whole picture, because many of my patients were not fat. They were not obese. They were not even overweight, even when you did body composition analysis. So that didn't make any sense to me. And that's why I started researching this area, because I believe that it is the insulin resistance that leads to the obesity that we're seeing, but it's undiagnosed insulin resistance. So I came across the work of Barbara Corky, and she is prolific in her publications. She has a huge lab. She puts out several papers during the year. And in 2011, she won the American Diabetes Association, what they call it, the Banting, after Dr. Banting, Lecture of the Year Award. Really what it was, it's a award given to the patient that has contributed the most to the field of diabetes. And she says, insulin resistance starts with a beta cell with hyperinsulinemia causing insulin resistance, but the initial cause is damage to the pancreatic beta cell. In 2014, up until that 2014, she'd be doing lots of literature on what are some of those things that can cause damage to the pancreatic beta cell. And she was looking at monoaleoglycerol, which is a food additive, iron, for example, saccharin, all these non-caloric sweeteners. But then in 2014, she published this amazing article that I hope you all have a chance to look at. And it's called, What Are We Putting in Our Food That Is Making Us Fat? Food additives, contaminants, and other putative contributors to obesity. And she was looking at obesity and insulin resistance. And so she went through and looked at toxins, but even things that we may not consider toxins. There are food additives that really are toxic to the pancreatic beta cell, like monoaleoglycerol for one. So I urge you to look at that paper because it was pretty amazing. So if we're trying to take all this information and apply it to ourselves and to our patients, how are we going to do it? I think we have to start with a history, and we have to look at that person's history in the womb. How were they born? Were they vaginally born? Was it a C-section? Were they breastfed? And how many antibiotic treatments have they had throughout their life? What has their diet been like? What habits have they had? What kind of job and what kind of hobbies have they had? What are their exposures? Remember my long list of different toxins? And it's really important that we consider the damages that may have occurred to the pancreatic beta cell as well as to the gut microbiota. I want to just for a minute have you look at this study. This was looking at the gut microbiome and how it develops and diversifies. And it's really in the first 15 months of birth that we sort of develop the robustness and what type or our gut microbiome is going to be like. What is it going to predominate? And so during those first 15 months, it's really crucial that we don't have a lot of outside influences like antibiotics, for instance. So can you imagine those babies that are, let's say, born in the hospital and they have to have an antibiotic within the first weeks of life, how they can really set up for them to have this very disordered or unhealthy gut microbiome? Because antibiotics really are the microbiome killer. This was a pretty interesting study. It was looking at the effects of 1 7-day course of one antibiotic. It was clindamycin. And what they did is they didn't give that patient any probiotics at the same time or thereafter, because usually you want to take probiotics for the duration, as long as you're taking that antibiotic, and you want to continue it for at least 2 weeks later. In this case, they didn't. And what they did is they looked at 24 months later, and they found that there were still changes to the gut microbiome. In other words, the gut microbiome had not restored itself. It had not regained normalcy or robustness or diversity from that 1 7-day course of clindamycin. The other thing we want to consider is B vitamins and methylation issues. And could this patient, for example, need more of a certain type of a B vitamin because maybe there's history of cancer or neuropathies or asthma or peripheral vascular disease in their history. So you want to try and put all that together, because usually it's in connecting the dots that we can figure out how we can best help patients. And then we want to consider previous diagnosis or diagnoses that we know are linked to insulin resistance and hyperinsulinemia, but maybe nobody really thought of it that way. So if we know, for example, if you have cardiovascular disease, you're most likely have insulin resistance. If you have hypertension, if you have polycystic ovarian syndrome, insulin resistance is the most important feature. If you have a previous history of cancer, if you have fatty liver or non-alcoholic fatty liver disease or NASH or non-alcoholic steatohepatitis. So from fatty liver, it can progress to a non-alcoholic hepatitis. And if it's not dealt with, it can even progress to a potential cancer down the line. So it's important to look at your liver function. And if the number one cause of elevated liver function tests in the United States is undiagnosed insulin resistance, but also obstructive sleep apnea. If anyone has sleep apnea, they're insulin resistant, and probably no one has really looked at that or told them that or has been treated that way. This is a study looking at obstructive sleep apnea in non-obese individuals and how it is significantly associated with impaired glucose metabolism, and that in itself can lead to future risk for diabetes if they're insulin resistant, but also for cardiovascular disease. So when you're taking a history, you also want to know what sort of symptoms does someone have? Do they have gastroesophageal reflux disease? Do they have bloating? And is it related to meals? Because that gives you an idea. Remember about my list. Is there a food sensitivity, but also is there a nutrient deficiency? Is there an insufficiency of a digestive enzyme, for instance, or your stomach acid, right? You want to look at digestion as a key for communication as well. And then, things like, are they constipated? They have abdominal pain? Is there diarrhea? So we're going to put together all that we get from the history, then with a physical exam. This is just my little area that Susan has been to, and I live right in here. But this is just to remind me of what symptoms or things you can look on a physical exam to establish, could I be at risk, or do I have insulin resistance? And maybe my doctor hasn't thought about it or isn't looking at it through these lenses. So things like body shape, especially the person who changes their body shape, where they gain a belly, or if they're a woman, they were very gynoid and they became android. So they had a hourglass type of figure and then they became more android. That's a sign that they could be insulin resistant. If they have acanthosis nigricans, that's that velvety brown area around the neck, the axilla, inguinal area, and the intertriginous area. Sometimes it could even be between the fingers. It can be on the elbows. There is a 90% correlation if you have acanthosis nigricans and you are Latino, that you are insulin resistant. Also things like skin tags or melasma, that discoloration, that brownish discoloration in your face. Hirsutism, if you're a woman, for instance, or hair loss, both if you're a man or a woman can be associated. Waist circumference, right? So to me, it's important that you also do an abdominal exam and you look at, what happens when you palpate someone's abdomen. Could there be something going on with the gut microbiome? And then we look at nails, because nails tell a story. If you have increased ridges, for example, the longitudinal ridges, that could be a sign of low stomach acid. If you have white spots, that can be a sign of low zinc. And then you want to look at muscle bulk, because that gives you an idea. If someone tells you that they're exercising pretty intensely and they're not gaining muscle mass, then that leads to you to believe, well, they may be catabolic or there's a hormone imbalance. And then mouth and tongue. To get an idea about vitamin B status, you can look in the mouth. You also get an idea about what's going on in the gut by just looking at the fissures in the tongue. And then this is my big plug for doing body composition, because I was told for many years that if someone isn't obese or they're not overweight, they could have increased visceral adiposity, and maybe that's why they're insulin resistant. I believe that it's quite the other way around. It's that insulin resistance can lead to obesity, as I mentioned, but someone can look thin on the outside and have increased visceral adiposity, and you may not know it unless you do body composition analysis. This is my slide to really help you or convince you that insulin resistance exists on this continuum. So just like you have wellness on one end and then illness on the other end, This is sort of my walking man slide to show, well, if you have insulin sensitivity and you're completely insulin sensitive on one end, and the other end is diabetes type 2, think of this continuum that from being insulin sensitive, you can go to insulin resistance, you can progress to impaired glucose tolerance, you can become pre-diabetic, and you can lead on and continue on to diabetes type 2. But what do we see in the last 15 years? We see more and more patients that are insulin resistant or even impaired glucose tolerant may now progress to prediabetes or diabetes, or we see more pre-diabetics. We actually have almost 3 times more pre-diabetics in the United States than we have diabetics type 2. And they may not be progressing, but yet they are suffering the same consequences. Increased risk of cardiovascular disease, of a stroke or a heart attack, as well as peripheral vascular disease. So those are the people we want to really diagnose and reverse. Because when we're talking about where do you see the manifestations on that continuum of whether they are insulin resistant or they have metabolic syndrome, and remember, to have metabolic syndrome, you have to have more than insulin resistance. You have to have 3 of the 5 criteria. But what I want you to think of is that you can suffer the consequences of being insulin resistant as if you were type 2 diabetic, and you may never progress. You may just be insulin resistant. So it's the insulin resistance that's key, and we want to make sure we're diagnosing. I'm not saying we don't want to diagnose prediabetes. Of course we do, and we want to be aggressive, and we want to reverse it. But to me, the earlier we start, the easier it is to reverse. So this is another picture of the north side of the island. I live on the south side. I showed you a picture of this vagin right in here. This is one that's actually one of the 10 wonders of Portugal. And I just wanted to shift that left brain to right brain and remember that, we need to consider something beautiful or something you like, or music or changes in sound for our brain then to be able to retain more information. So let's move on to what labs would you want to do? I want to do things like your adiponectin and your insulin. And adiponectin is a marker that we've had now for about 8 years. I actually waited for this marker to come out because it's something that decreases before insulin increases. And I wanted an earlier marker. So it's a very good marker, but we know that now that some patients genetically may have a normal adiponectin level and still be insulin resistant. So we can't just use that. Proinsulin is a marker when you're having pancreatic beta cell dysfunction and your insulin is being kicked out before it's fully ready, before that final cleavage. So it gives you an idea about how much pancreatic beta cell dysfunction there is. Hemoglobin A1C, of course, is measuring the amount of sugar or glucose that's bound to the hemoglobin ring. And the amazing thing about hemoglobin A1C is that it wasn't developed to detect diabetes. It was developed to see if diabetic patients were compliant, and especially diabetic type 2. And so it was for a long time used for that only, and people were being told that by their doctors that they just needed a level of 7 because that was control. Well, a normal hemoglobin A1C is 5.3 or less, and that's what we want, right? We want optimal. We just don't want to be in the range. And then insulin, you want to do fasting. I like doing a 30-minute and a 1-hour load. So in other words, you eat 75 grams of glucose more or less, and then you test to see, it's a challenge test to see how high you go. Because if you are relying just on your fasting insulin and your fasting glucose, like if you're using the HOMA IR, for instance, you may miss some patients because it's the postprandial insulin that goes first. So the first thing to increase isn't your fasting insulin, it's your postprandial insulin. And then NMR lipid profile, that's your expanded lipid panels. Of course, we want to do some more of our more conventional labs, but we look at it through functional eyes. GGTP gives you an idea of how much inflammation there may be in the liver. It's also sort of a poor person's measure of glutathione. You want levels low, like 25. I like less than 30. Uric acid, amazing studies in the last few years about uric acid as a marker for insulin resistance. So anything above 6 is insulin resistant until proven otherwise. So it's not just a marker for gout, it's also a marker for inflammation, in particular for insulin resistance. And then your comprehensive stool analysis to look at your gut microbiota. This study was looking at glycated hemoglobin A1C in what's called the normal range. Well, it's not the normal range, it's a reference range of greater than 5.5 is associated with insulin resistance. There's actually more studies showing that a hemoglobin A1C of 4 or above is an independent risk factor for heart disease. So you want your hemoglobin A1C 5.3 or less. Insulin concentration after 30 minutes, that's just a study to show that there are some people that secrete their insulin maximally at 30 minutes, not at 1 hour. So you may want to consider that and talking to your doctor about that. Comprehensive digestive stool analysis is going to talk to you about or give you information about the diversity of your microbiome. Also, your microbiology. Is there a pathogenic organism? Is it a fungus? Is it a bacteria? Is it a parasite? It's going to tell you about those short-chain fatty acids, and it's also going to give you an idea of what's going on with your pancreatic function. Other labs you want to consider, things like vitamin D, homocysteine, your CRP, a nutrient analysis, and then markers of actual damage to the membrane, so the endothelial membrane of your blood vessel. So things like LPPLA2, which is it's a microvascular plaque marker, and myeloperoxidase, which actually it's made by macrophages and actually shows that there's been damage to that endothelial wall. And then, of course, if you suspect toxins, you're going to look for those heavy metal panels. So I like to explore, and I particularly like to explore caves. And on the north side of the island, there's these great rock formations. And in addition, there's also these little nooks and crannies that you can go to. Some of them are caves. I found this one interesting. This is actually low tide at the time, but this is a small little swimming pool. And in the middle, there's a rock that's like the almost perfect shape of the island itself. I just thought that was really interesting. So let's look at treatment now. What would we do, and how would we approach treatment to reverse insulin resistance? I think first we have to look at what is happening to our food, right? And the fact that the standard American diet is very low in fiber and high in sugars and refined grains, and that then we have this whole sort of supersized phenomenon, and it's also high in saturated fats. And even when we've done away with trans fats, we still are eating a high amounts of your hydrogenated fats, which in my book are just as bad. Not to mention the fact that we've supersized everything. So my approach is really to start with food. That's our foundation. And I don't like using the word diet, but I want to think of your nutrition and nutritional status. So you want to start with wholesome, fresh, and processed, organic whenever possible, colorful, that's high in fiber, that it's fermented, that includes nuts and seeds, and it includes both your soluble as well as your insoluble fiber. So I always say 10 to 12 servings of vegetables and fruit per day. A serving is a half a cup of a cooked vegetable. So a half a cup of steamed asparagus, a half a cup of steamed carrots or broccoli. If you're looking at a raw leafy green vegetable like your lettuce or arugula or your spinach, then a cup is 1 serving. So I want 10 to 12 of those, usually 10 of vegetables, 2 of your fruit, and predominantly your low glycemic load fruit. So all your berries, your blueberries, your raspberries, your strawberries, and kiwi. Those are all low glycemic index or low glycemic load. And then you want to do as much as you can to also increase your soluble fiber. And I want 35 grams of soluble fiber. And those are mostly your nuts and seeds. So things like chia seeds and flaxseed meal and your whole hemp hearts and coconut flour, and my all-time favorite, chestnuts, because chestnuts are very high in butyrate. Remember I told you butyrate was the short-chain fatty acid that fuels and feeds the colonocytes. Right? It helps that mucin layer, helps protect the gut microbiota. It actually feeds the gut microbiota. And then you want to fix the underlying causes. You want to try and decrease insulin stimulation. You want to personalize diet or the nutritional plan. And then we want to address lifestyle modification in all our patients. What do we need to do to decrease insulin resistance and increase insulin sensitivity? Thinking of digestion as well as sleep and movement. And then, of course, we're going to use some supplements, but we're going to target it. And food is our foundation. And we have to address that mind-body connection and how is stress affecting our mind, body, and spirit. And then we want to work on detoxification, in particular because we live in a toxic world, but we also know the toxins can really affect the pancreatic beta cell. So because I'm simple and I like keeping things simple, I've decreased that into 3 main things we want to do when we're thinking about treating the insulin resistant person. Decrease insulin stimulation, modify the gut microbiota, and increase your cellular responsiveness to insulin. So we're going to decrease insulin stimulation by foods, first and foremost. And remember when I said those 10 servings of vegetables, how are we going to get them through in a day? Well, I do a lot of soups that are cream of vegetable soups that don't include any cream, cream per se, the milk or the dairy product, but we're doing it whether it's a cream of spinach or it's a cream of broccoli or asparagus, my all-time favorite because it is so high in glutathione. And then you're going to add other vegetables to it. So in one meal, you may be already getting 4 to 5 servings. And then, of course, you're going to have your steamed vegetables and your salad, and you're going to eat like the rainbow with lots of different color because color equals different types of phytonutrients. And then we're going to really look at what are good fats versus bad fats and increase more of the good fats. Things like your extra virgin olive oil, your avocados, for instance, which, by the way, avocados are also high in glutathione. And then we're going to work to modify the gut microbiota, starting with food first, looking at our fermented foods. And with fermentation, I have my patients actually ferment their own foods, and I tell them what to use as a starter, because I know that certain starters are going to work more at the level of insulin resistance, of decreasing insulin resistance. And then we're going to increase cellular responsiveness to insulin. And we're going to do that again with food first, things like spices and herbs, right? You want to include as many herbs and spices in the diet as possible. And then we're going to add our supplements, because our supplements work with or synergistic with substances in our food, some of which we haven't even identified. This is looking at the fact that some patients are more sensitive to the effects of glycemic load. And so you want to take glycemic load into consideration and not just looking at glycemic index. But when we put all this together, there's such synergism. There's so much we can do. Because as this study points out, just by limiting sugar to 5 to 10% of the total caloric intake, the harmful effects of insulin resistance could be minimized. And it's when you put all these things together that you really see a huge difference. The other is artificial sweeteners, doing away with artificial sweeteners because they affect the gut microbiota in a negative way. The only thing I'll allow is for now is stevia, because we don't have a lot of literature showing that that's not an okay sweetener. But mostly I want people to get used to the taste of food and not necessarily just the salt and the sweetness, but to really try and decrease the sweetness and do it more naturally. You can also do caloric restriction. We know from all our Roux-en-Y and gastric bypass patients that in itself can modify the gut microbiota, and it can improve also your beta cell function, which results in improved sensitivity. But also things like lowering LPS just by the amount of times that we eat during the day. Of course, there's some patients that may be having other issues, and they may need to eat and snack more frequently. But just be aware that there is a sort of method to my madness in saying we may want to do a little bit of bowel rest. And it may be actually one of the ways in which intermittent fasting works, because we know that intermittent fasting does sort of decrease the effects of LPS, but it also works in pancreatic beta cell dysfunction, right, in helping the beta cell itself. And we know that when it comes to intermittent fasting, I'm always asked, well, how many hours? Well, we have studies on 12, 14, 16, and 18 hours. It looks like with respect to insulin resistance, and this is according to the work of Jason Fung, it may actually be closer to 18 hours. So what I encourage my patients is every day do 12 hours from the time they eat dinner to the time that they eat breakfast the next day. And 3 days a week, try to do 18 hours. I know there's people doing a lot more than that, but you have to really take this individually with each patient. In addition, I'm already doing a modified elimination diet. So I'm eliminating things like gluten and dairy and soy and all the inflammatory foods. When we look at insulin resistance, the diet that sort of has the most support for is the Mediterranean diet, but it's the Mediterranean diet that is varied in color, like the rainbow, has extra virgin olive oil, right? But it's also looking at, well, what are the exposures? What has happened in that patient thus far? Because you want to include foods that are also high phytonutrients, so they're chemically, or I should say phytonutriently, very dense. But you also want to look at your fermented foods, as I had mentioned earlier. I like this study because this talks about personalization and the fact that no two insulin resistant patients are alike. And one person, like I, may have a different glycemic response to something that is even low glycemic load. And it isn't until you test that you really can get an idea, and that it needs to be personalized. And now that we also have the Libra, for example, the continuous glucose monitoring, it can really help with that. But if you're insulin resistant and your glucose isn't going up, so your sugar isn't going up, you need to look more also at what things can affect your insulin and not just your glucose, because I'm all about trying to diagnose things earlier. The earlier, the better. I love this slide. This was done by two good friends, Diana Minnick and Jeff Bland, and they were looking at how do these phytonutrients work. So whether you're talking about a spice like cinnamon or berberine, for instance, or you're looking at a supplement like quercetin or resveratrol, whether you're getting it from food or in a supplement, it's working on that same receptor to try and help decrease inflammation, but also to help insulin get inside the cell. So it's amazing what you can do with food alone. And I mostly mentioned your spices, but your herbs work the same way, whether it's basil or rosemary or thyme or dill. They're going to work by working on that insulin receptor and decreasing inflammation. This is an area that I grew up. These are all natural pools. They're volcanic pools that are naturally made. And one thing I wanted to point out is this particular area happens to be about 20 feet deep, but the water is so clear that you can actually see the rocks on the bottom. Let's switch a little bit now, talking about, so I talked about food and what type of food you want to use to address insulin resistance. We're going to move now on to a little bit more on the gut microbiota, and then I'm going to end with the supplements and the nutrients that have a little bit more information. There's many, I'm just covering a few with respect to insulin resistance. And this is talking about diet, but especially the fact that it's the low fiber diet that contributes to obesity and insulin resistance because it impacts the gut microbiota. And when I say that you need to have 10 to 12 servings of vegetables and fruit, there we're talking predominantly about your insoluble fiber. But it's the nuts and seeds, so the flaxseed, the chia seeds, the chestnuts that are going to be more of your soluble fiber that's going to really impact the gut microbiota. And would you believe it, with food alone, you can actually change the gut microbiome within 24 hours of starting that diet. This was unheard of when this study first came out, because for years it was believed that whatever your microbiome is, that you're stuck with it and you can't change it. You actually can. Pretty amazing. It can be manipulated with your diet by prebiotics, probiotics, as well as antibiotics when you're talking about it in a less than favorable way. I'm going to cover the probiotics that have the most literature support when you're looking at insulin resistance per se. So this is looking at Lactobacillus reuteri. It's found over the counter. It's in children's formula for colic, for instance, and has been shown to actually decrease insulin resistance and also decrease obesity, even when this was done in mice, even when the diet itself wasn't changed. Now, I'm not advocating that, but think of how synergistic things can be. So if you're adding a probiotic and you're changing the diet, just think of how much can be attained. This is looking at another probiotic. This is Lactobacillus gasseri BNR17, also been shown to affect insulin resistance. And remember that in sometimes studies are done in single strain probiotics, but we have more studies looking at multiple strain probiotics. And remember that probiotics can, they can sort of repopulate, but they can also act on the growth substrates for bacteria. They have some immune modulating effects. There's a lot to be said for how they work. This is looking at Lactobacillus casei, again, also a good one to use for insulin resistance and diabetes. VSL number 3, and we're seeing a lot more of studies looking at more than one thing at a time, right? And like that one pill for a nil approach. So we're looking at, for example, VSL number 3 with omega-3s and how that together can lower your insulin resistance, increase your insulin sensitivity, lower CRP, right? Have a positive effect on your HDL, for instance. Lactobacillus plantarum is another, and this is what I like using for making kefir or yogurt, and I do it non-dairy, so you can do it with all your nut milks, for instance. I use a lot of creamed coconut where you can reconstitute in water and use that to make your kefir or your yogurt. So a lot to be said for fermentation. And what about movement and exercise and putting all this together? So this was an interesting study. This was the diabetes prevention group that was actually stopped in 2002. That was its midpoint. And this is pretty interesting. So this was a study where they divided the people into 3 groups. One were just given a diet and basically told to follow it, and they were sent home and basically not followed regularly. The other group were given metformin, right, a prescription drug, and the third group were put on this diet, and they were all, it wasn't actually that strict of a diet. They had 150 minutes per week of exercise, and they met every 2 weeks in person, and every week they were contacted by the phone to see how you're doing. So there was a lot of interaction in that group. And so which of these do you think did better? Because people who are not so well educated in many cases think that it was the pharmacological group, the group that received the metformin. Actually, it wasn't. It was a lifestyle group. And I think it was because of the synergistic effect, and they had support. They relied on each other. They went on walks together. They were contacted by phone. And that has a lot to do with how successful someone can be, especially when they're trying to change their lifestyle and their diet. And so the lifestyle group decreased the incidence of diabetes by 58%, the metformin only by 31%. So almost twice as much with the lifestyle. This was supposed to be a much longer study. It ended it in 2002 at the midway point because they would have had to offer the lifestyle group to the placebo and to the metformin, and that was going to be too expensive. But imagine what we would have found out if we had been able to cross over and then offer that to the people that were on the placebo and or those who were on the drugs. I think it would have been an interesting outcome. This is looking at lifestyle and especially movement, and how it's not so much about doing, an intense exercise routine. It's about tailoring it to your needs. And high intensity interval training is a great way. You can do it even just 7 minutes a day, but it really depends on each person. Like, I don't like going to a gym, but I love to do stand-up paddleboarding. I love to swim. I love to dance. I love to do hikes. So we have to approach that same way with our patients. And we know that even just contracting your muscles or movement can decrease insulin resistance. Sleep. I cannot talk to you enough about the importance of sleep. Sleeping 8 hours per night is of the utmost importance. Now let's move on to some of the nutrients, things like alpha-lipoic acid and chromium and coenzyme Q10, vitamin D, your magnesium. your other antioxidants, your omega-3 fatty acids, vanadium, your serum kinase receptor modulators, a big one of which is omega-3s. And we know that with respect to alpha lipoic acid, sometimes if someone has peripheral neuropathy, you may need to use higher doses. So I usually start at 200, and there's studies on 200 milligrams. But if you already have polyneuropathy, or you're having problems with circulation, you may need to use higher levels. Same thing with CoQ10. The studies have shown changes at 120 and 200 milligrams, but we want to measure hemoglobin. We want to measure your CoQ10 level, and we want it above 3. That's the latest from Dr. Steven Sinatra, who's the cardiologist that basically put CoQ10 on the map. And then vitamin D, you want to make sure you're measuring levels. And of course, we want at least a level, I used to say a level of 50, but now in COVID times, we know that you want a little bit higher, like at 60 nanograms per milliliter in the serum. And then magnesium, my favorite mineral. You can, as long as you don't have any problems with your kidneys, you can do it to bowel tolerance. It's always good to make sure that you have a lab that shows that you have normal kidney function. I prefer magnesium glycinate because it doesn't have as many effects on the bowel, so it doesn't cause loose stool as much, and it's very well absorbed. Now, there's a lot more nutrients that I could talk about, but these are sort of my main ones that I use. There's things like quercetin, of course, and curcumin and resveratrol, but I was just keeping things simple, and these are sort of the ones that I start out with. So remember, 3 main ways to approach insulin resistance, and that is by you're going to decrease your insulin stimulation, food, lifestyle. You're going to address the gut microbiota. You can add you remember those 10 to 12 servings of vegetables and fruit, your 35 grams of soluble fiber is going to go a long way. But then you also have your probiotics, and the fiber is a prebiotic. And then you're going to add those spices and herbs that are going to work at that insulin receptor. And in addition, then you're going to do your nutraceutical supplementation. And I hope this has been useful. You can contact me on my website, and I hope you join me at some point in time and come to the Azores and do some of my retreats as Susan has done. And now I'm going to look at your questions.
We have one question in the chat about asking if monk fruit is okay as a sweetener.
That's a good point. As of now, I will still allow it. I try to allow it in moderation because we don't have a lot of information yet. It looks like it could possibly have a effect on insulin, but I haven't seen enough studies. So for now, with my patients, I still allow it, but I do it in moderation. And I'm really trying to get people to not rely so much on their sweetness. So what happens is we lose our taste buds. We are only able to taste sweet and salty. So we tend to oversalt and want more sweet things because that's the only thing we can taste. But there's a reason for that, and it's usually nutrient deficiency. Zinc is a major one, selenium is another. So if that's the case, I try to figure out what are the deficiencies so that we can sort of open our palate and not be so dependent on that salt or that sweet. And really also to get used to, using less sweeteners in general.
We have a question about how can we ferment our own food at home, and can you address this from the point of view of your clients and what they find easiest to do to modify their lifestyle?
So I find, I'll answer the second part first. So I find that the easiest thing to, or sort of what I can do the most, or what people usually require the most to help modify their lifestyle is the tools. And tools and support is number one, knowing exactly what to do, what they need to do. So step by step. And number two, having support, whether it's their health provider or it's someone else that's doing it with them, or it's a nutritionist, regardless. I think that it's not easy for any of us to change, but it's a lot harder for us to change when we don't have set goals or goals that are achievable, and we don't know what steps to take. So I find it that sort of sometimes I have to be that support or I have to hold someone's hand, but it's all about working together. I think that makes a huge difference. Now, when it comes to fermenting, I like doing all my own fermenting. You can find me on YouTube. I show you how I do my kefir and my yogurt. I like using cultures that have been shown to work towards insulin resistance, for example. So I will use Lactobacillus plantarum. You can use that by itself, or that's a probiotic. So you can just use the probiotic itself. You could use almost any probiotic. The secret is you have to make sure that it's not going to compete with bacteria already present in whatever liquid you're using or in the environment in your home. So I'm just going to give you one example that I use a lot of. You can buy the creamed coconut. It's not coconut cream, it's creamed coconut, which means someone opened a coconut, they took out the coconut water and they scooped that gel part as well as the small fiber and the large fiber and the fat, and they packaged it. And you can get it organic. I reconstitute 1 cube, it's actually more like a rectangle, in 1 liter of water. And it's solid, so you want to bring it to a boil. And then once you bring it to a boil, you turn off your stove, and then you want the temperature to be at about 110 degrees because you don't want to kill your starter. When it's 110 degrees, you add your starter, whether you're doing your Lactobacillus plantarum, or I really like the starters by Body Ecology. I have no financial relationship with them. I just happen to like their starters. Then you add your starter, and then you want to put it in a glass jar or use your yogurt. If you have your glass yogurt maker little jars, and you want to put a lid on it because you don't want competition with the bacteria in your kitchen or in your house. And then you want to keep that warm. So if you have a yogurt maker, you can do that. If your stove or your oven has a pilot, you can put it in there. You can even take a cooler and fill it up with hot boiling water, throw out the water, and then put your glass jar in there and put the lid on it because that will keep it warm. Sometimes when it's hot in the summer, you may not need to do that. And then you let it ferment. And I like letting it ferment 12 to 24 hours. You can do that with nut milks like macadamia, for example, or almond milk. With macadamia, there isn't much in the form of carbohydrates. So sometimes I'll add a little bit of honey just to get the probiotic bacteria to grow and multiply. And you can do kefir the same way. It's just a little bit different in consistency, but I find that fermented foods go a long way. You can also make your sauerkraut, for instance. You can use that starter, or you can choose not to use a starter, basically use what's in your house. I like doing sort of directed starters, or because I'm trying to reach something and I'm going by the science behind it because I want to get a certain outcome. So for example, if I use Lactobacillus plantarum, I know that it helps degrade histamine, it helps degrade oxalates, and it works on insulin resistance.
If anybody has a question and you're on a cell phone, this is the time to unmute yourself and ask your question. It seems your presentation was so clear that we don't have much in the way of questions.
Well, I just think that we have a very astute and a very smart and well-educated audience. And so they know this stuff already, which I know is true because I've been there in person.
Any people have any questions on anything else on health? Since Filomena is an expert and teaches all the functional medicine practitioners, this is your time to ask her questions.
Yeah, open up the topic. Brian.
Yeah, I was wondering if you could repeat what you said about chestnuts. I've never heard anybody say that chestnuts was such a phenomenal thing before.
Oh, yeah. So one of my favorites, actually. So chestnuts, when you look at chestnuts and you sort of investigate them, they actually look like they're a high glycemic food, but they're not, because they're very fibrous. And chestnuts are taken by our gut microbiota and are converted into butyrate. And I said butyrate is a fuel for the colonocytes, but it's also a way to heal and restore sort of the normal gut microbiota, and it actually feeds the good bacteria in our guts. It's pretty interesting. You know, I grew up eating chestnuts, but when I came to the US, that became more of a delicacy. And so some things that you do, like we always do it around November when they're being harvested. And then a few years ago, I heard a talk by Dr. David Perlmutter, and he's a good friend and a really amazing human being. And he tells the story how he went to Tuscany, and he was filming, because he was really into photography. He was filming and he saw these huge fields and lots of trees, and he was trying to figure out what they were. And so he went down and saw that they were all chestnuts. And he started asking, what do people use chestnuts for? And they're like, oh, we make soups and we make cupcakes. We use it's a staple. And so he investigated, and he did this big, actually, I think you can still find it on YouTube. He did this big talk on, because he was really into the gut microbiome. He started at that point in time. And he started to research the chestnuts and their effects on the gut microbiome, and found that, wow, this is amazing. It's an amazing source of a soluble fiber. It's really good for you. And he's even been talking about how it can sort of help with detoxification. And that's how it came up. It's sort of taking something that I grew up with and then learning the science behind it.
Yeah,
and by the way,
I've only had chestnuts at Christmas time where you roast them and crack them open. I just did it on Amazon. You can get roasted shells, organic chestnuts, a bag of them for like $8. So if that's a thing to just add to your diet, that's pretty awesome.
Yeah, and you can even buy them already cooked. So yeah, I love roasting stuff. So that's a lot of fun. But
Yeah.
by Geffen, Gefen, the company, they have them in these bags, just like you would buy like potato chips, and they're already cooked. And there's about I think there's about like 16 or 20 chestnuts, and it's a great snack. And sometimes I just chop them up, and you can put them in your oatmeal or in your salads, and they're healthy.
Thank you.
You're welcome.
Darrell?
Yes, hi, thank you. What a great presentation.
Thank you.
My question is on soil-based probiotics. I know we spoke a lot about the lactate producing and a little bit about the bifidus, but what about this whole idea about soil-based and these formulas that are coming out, and that could really populate a microbiome much more than these other, and also the second part would be, is there a time when fermentation for someone with high histamine, or they have an issue, is there a time when we hold off on fermented products?
So I'm going to answer the second part first. So that's one of the reasons why I use Lactobacillus plantarum, because it degrades histamine. Because I was always told, you have to be careful with fermented products in people with a histamine intolerance. So I started thinking, well, what about all these cultures that, of the world that use such high amounts of fermented food products, my own included. And so I started researching it. And it all depends on what you're using as your starter. And I use Lactobacillus plantarum a lot for that reason, because it actually degrades the histamine. So I don't have to put anyone on a low histamine diet. It also helps degrade oxalate. So that's sort of less that I have to worry about in terms of limiting, someone's diet. In response to your question on soil-based probiotics, that's a great question. So there is some literature about your soil-based probiotics being more involved with inoculation versus repopulation. So you can repopulate with any probiotic, but there is a thought or a school of belief that perhaps you need the soil-based ones to do more of the inoculation. The fact is that there's a lot of talk, but there's not a lot of science. There's a few studies coming out, and I do use some soil-based probiotics, especially in those patients that I'm having a difficult time repopulating. I prefer to also just have it from the soil itself. So I think that there's some things in nature that we may not know enough about. So as long as I feel like someone can tolerate it and they have their own garden, eat some of their vegetables and they're not using any chemicals. It's all organic. You can use your carrots that not so well washed, and you're getting some of that soil-based organisms. Because as of now, yes, we have some studies. I think that we're jumping on the bandwagon. We're using them a lot, and there's not as much science as I would like to see. There probably will be more in the future. So for now, I am using them, but I'm using them together also with the ones that have a lot more research behind them, like VSL number 3, for example. There's tons of research on it. So I tend to use it a lot because I want to treat the whole person, but I also want to stay within the science.
Thank you very much. If you don't mind, maybe just one other question about coconut and
sure.
the LPS translocation. The fact that research on coconut oil and the idea that could be worsening the LPS and that would be a surprise for so many people using that.
Great question. So if you look at those studies, because we have quite a bit of studies with positive outcomes using coconut, right? Whether you're looking at it with respect to Alzheimer's or dementia in general. And then we have a couple of studies showing, well, maybe it's problematic. Well, if you dissect those studies apart and you really look at them, I think that you have to worry a little bit about using high doses of coconut oil in patients who have a very unhealthy fat diet. So they're eating lots of unhealthy saturated fats, and they're not able to degrade their LPS. And then you're adding this coconut oil on top of it. So if you're cleaning someone's diet and you're making sure they're eating those 10 to 12 servings, like I said, and you're removing the unhealthy saturated fats, I don't see any problem with adding the coconut oil. It's all you have to you have to really tease the study apart, because when it first came out, it was like, oh, coconut oil is bad and you can't use it and it's, increases the LPS. But you have to actually tease it apart and really look and see, well, who were they studying? What was the protoplasm they were using? And what was really found? Not necessarily what was publicized to have been found, but what did the study actually find? Because you can't argue with all the positive studies. You have to figure out, why is this a negative study, right? You have to sort of take it all in and then try and figure out, does it make sense and how was it done? That's a really good question.
Thank you very much. Thank you.
Susan? You have any questions?
Well, there's some questions of describing the NLRP inflammasome. What is it and what impacts it? And there was a question on making yogurt. Do you recommend goat milk? I heard you say you can use any kind of milk, but somebody had a question of cow's milk versus goat milk.
Well, because dairy can be inflammatory for some people, I tend not to use a dairy type of milk, but you can. I like using raw milk, whether it's goat, or if you're going to use dairy, whether it's goat or cow's milk. And if you know the source, right, we know that the milk from a Jersey cow is a different type of casein, and that it tends to be less inflammatory and do less allergic reactions. So I think that that's actually, if you're going to do dairy, that would be the best one to use. I think that there's something that happens in the process of pasteurization and homogenization too, that alters, the fats. And I think that, and probably the carbohydrates as well, that may be part of the reason why it becomes more inflammatory. So if you can do it if it's not an issue and you can do raw milk, so much the better. And then what was the question on the inflammasome?
Please describe the NLRP inflammasome. What is it and what impacts it? I'm not sure what that refers to.
I have an idea what it refers to, but I'm not sure all that impacts it besides diet and nutrition. sort of an unhealthy diet and toxins. Other than that, I'm not sure what else impacts it. Lifestyle, I know for a fact, but most of the studies that I've read are talking more about your unhealthy fat diet, for instance, or your sort of nutrient depleted diet. I'd much rather focus on your the antioxidant response element, an ARE, and how you can stimulate that with food to then fight inflammation, such as, for example, foods that are high in glucosinolates or that are high in glutathione, for instance. And we know, for example, that broccoli has glucosinolates, or all the cruciferous vegetables, but it's when it's a process of chewing it, right, with the myrosinase in our saliva that then sort of liberates the sulforaphane, which can act on our cell's own intrinsic antioxidant response element to make the cell make more antioxidants. In general, I try to see what can we do with nature and how can we help our body help itself.
I have a question. What do you recommend to keep us healthy in the times of COVID? And if we start having symptoms, what do you recommend?
Great idea. So I recommend keeping up with your zinc and your vitamin C. We know that if you do get COVID, it really lowers your zinc. And I've seen that happen in my patients where they'll lose their taste. And it's the one thing that takes the longest for them to recover from. So definitely zinc, vitamin C. I always say at least 2 grams of vitamin C per day. Zinc, you have to be careful with your ratio with copper. So usually you want 1 milligram of copper to 10 to 15 milligrams of zinc. And I want my patients to be at least on 30 milligrams of zinc. And if they're at high risk of exposure, I'll go up to 50 milligrams. I have all my patients on glutathione and glutathione precursors of at least 250 to 500 milligrams of glutathione, and then things like N-acetylcysteine, for instance. I want to make sure their vitamin D level is at least at 60 in the serum. And then, there's been quite a few studies on quercetin and the importance of quercetin as well, like 500 milligrams twice a day. So that's what I do to prevent. And then my biggest thing I feel like too is looking at people's exposures, making sure they're getting a healthy diet, but really focusing on stress, because we are living in such a fear environment. And fear is going to lower your immune defenses like anything else that I could possibly think about. So really trying to, in this sort of keep the distance, at the same time, also try to see what can I do to decrease my stress levels and to go from, instead of the stress mode, more into like attend or befriend or hopeful mode. And also believe that, our bodies is an amazing thing, and that I feel like the average body is smarter than the smartest doctor. So rely also on its own intrinsic sort of thought processes and wisdom, because if you can just sit and listen to your body, it will tell you what it needs. And really focus on being totally healthy, not just the food you ingest, but the company you keep, the thoughts that you think while you're ingesting that food. Because we know that someone's eating blueberries, if they think about the fact that those blueberries are going to talk to their DNA and that they're very high in antioxidants, it actually increases their effect, right? They become even more and more effective. Their antioxidant value actually goes up. It's all about the power of intention and knowing, and also just slowing down while you're eating. And then so I do a lot to sort of prevent COVID. If you do happen to get COVID, a couple of things I would have you do. Number one, there was a study published on glutathione, and this was on oral glutathione. 2 grams oral glutathione at one time actually decrease sort of the cytokine storm in the lungs. Now, I had someone with a severe case of COVID, And I kept them on 2 grams of glutathione for 2 weeks. So I didn't do it just one day. But the study by Richard Horowitz and some of his colleagues was on 2 grams oral at once. I have found that you may need still to continue on the vitamin D. One thing I forgot to mention was the probiotics. I mentioned the zinc, the D, the C, but I forgot the probiotics. I have found that you may need that high level of glutathione for a little bit longer. And I also like keeping with the precursors like alpha-lipoic acid and acetylcysteine and selenium, making sure you're getting plenty of that. We're seeing some studies now also on selenium and COVID. And if you have access to, let's say that you think you have COVID and you have access to an IV, you can also do glutathione IV, but you don't need to because the study was on oral with really good outcome.
There was a question on what do you think about a vegetarian diet?
Well, I think that as vegetarians, we need to be concerned about getting sufficient protein. And also too, people say they're vegetarian, but sometimes they may be, that doesn't mean they're eating healthily in some cases, right? So you can be a vegetarian and be healthy, but you really have to monitor the amount of protein that you're ingesting and the amount of omega-3 and making sure that you're getting the activated B vitamins. It's not impossible. It just makes it a little bit more difficult. And the one thing that is not often talked about, but I find a big issue with vegetarians is coenzyme Q10. So CoQ10 is an animal product, right? It's in organ meats. It's extremely important to protect our immune system, especially in COVID times. And so you either need to supplement if you're not eating fish, or mostly it's fish and chicken and beef where you get the coenzyme Q10. Then you want to make sure you're supplementing with it, which I hadn't added that, because you'll have less sources of CoQ10 since the predominant source is a non-vegetable source.
Brian, again, welcome back.
Yeah, thank you for round 2. And I sure hope I'm not showing my ignorance on this one, but I was under the assumption that glutathione could only be done by intravenous injections. And you've said a couple of times to take glutathione, and you've talked about glutathione being in food. So I'm wondering if you could set me straight on that one.
Sure. Actually, glutathione is you can use it orally. You can use it transdermally, not as well. It's a big molecule. So we often think of it IV, and you're absolutely right. I use it IV, I give it IV, but you can also do it orally. And the best form, there's reduced glutathione and there's a liposomal form, and the liposomal form is better absorbed. And that was the form that was actually studied with respect to COVID, but you can absolutely also do it orally and it works well. Now I measure glutathione levels, and my biggest thing is, well, are they really absorbing it? So I've measured levels before starting someone on oral and then after. And yes, indeed, you're able to keep your levels up. Now, there was one other thing I didn't mention, but you can also take glutathione inhaled, right, in addition to injected. For some people, it's a little risky because it can be irritating to the lungs. So I actually have stayed away from doing that with COVID patients, but definitely you can use it orally and you can use the precursors. And back to food. So there was a study from 1936 on a patient with a glioblastoma that was basically given 3 months to live and said, there's nothing else we can do for you. What he did is he read about asparagus and started eating asparagus every day, and lived, I think it was 9 or 10 years longer. And that was the only thing he changed in his diet. So then that led me to say, okay, asparagus, what's in asparagus? Well, asparagus is very high in glutathione, and so is avocado, for instance. And there's a lot to be said for these nutrients in food that may promote what we're taking as a supplement, that some of which hasn't even been studied.
Right. Yeah. So the oral glutathione that you mentioned, is that something available over the counter, or is that
Yes.
doctor prescribed?
No, you can get it over the counter. A lot of different companies will make it. I like the liposomal form because it's better absorbed. There's also the reduced glutathione that you can get. I would just get it from a GMP certified company so that you know that it's quality that you're getting.
Thank you very much.
You're welcome.
And I, since I have the floor, I love your integration of the photos into the presentation. That is just brilliant. And I 100% agree with you that helps the left brain, right brain, and the learning. So thank you very much.
Thank you. I appreciate it. I never know how it's going to be received. So thank you for that.
Darrell?
Yes, hi, and thank you very much. This goes along with a few of the other questions, so I hope it will be helpful. The vegetarianism one and the diets that you mentioned, the Mediterranean diet, and the fact that I think you mentioned that you're in Portugal, right? Is that the
I'm in the Azores Islands, and they're in the middle of the Atlantic Ocean. But they're Portuguese islands, yes.
Okay, well, the big question, and this is really, really important, is that there's many studies coming out about the Mediterranean diet. And I just read one about Hashimoto's, and the way they describe it, as it's been described over the last 10 or 15 years, is a low fat or relatively limited in red meat. And they, obviously talk a little bit about some extra fish and push a lot of nuts and seeds. But the original Mediterranean diet, and you're living actually there right now. So that's why this question is so important. Have they changed, or they being the diet authorities that do dictate kind of the guidelines? They've been very reluctant to say the Mediterranean diet is any higher in saturated fat or animal fats or red meat. Whereas if you could give us what is the real Mediterranean diet, you're living right there. If you could let us know, has it been hijacked by the authorities to be, and we're not really knowing what it is, because the way they're describing it is as a low fat, maybe a little extra fish. And they if you could help with that, it would help a lot of us here in the States.
Oh my goodness, the whole big fat fiasco. It just never ceases to amaze me, because it's actually not really a low fat diet. It's, I grew up eating lots of fish and olive oil, and, that's not necessarily low fat. It's a good, healthy type of fat, right? And meat, not just, very scarcely. Yeah, it wasn't that we had a lot more fish than meat, for example. But and it has been hijacked, by the way, unfortunately, because the big U.S. has sort of influences everybody. But let's just take a step back and let's look at, for example, the fact that the Mediterranean diet has changed a little bit, and it's one big fat term. But what do they really mean when we talk about it? We talk about eating like the rainbow when you look at the studies, right? So it has lots of vegetables and it's colorful, and it has like the different colors of the rainbow. It has fish. It has some meat. It has your extra virgin olive oil, right? That's sort of a very type of diet. But let's even look when we're considering just the fat, because that really sort of irks me. The fact that when we talk about it's low fat, no, it's low in your inflammatory fat, right? It's low in your hydrogenated fat. It is not a low fat, even though many authorities are trying to promote it that way. But let's just look at the blue zones, right? One of which is in Sardinia. Another is in Greece, right? Ikata, Greece. One is here in the United States, in Loma Linda. The other is in Costa Rica. And I think I'm forgetting one area. So those are the highest concentrations of centenarians, right? When you look at their diet, was it a low-fat diet? Absolutely not. Ikata, Greece, what did they eat? Well, they actually had, high cheese, some meat. There was their amount. Oh, Okinawa was the other area that I forgot to mention. They drank the red wine. That's sort of where they got the resveratrol from. Let's look at Okinawa, for example. Well, it wasn't just about the Okinawan sweet potato. Those are people that underwent very harsh times. They underwent famine. They saw their loved ones being killed. Right? They lost their friends, and yet they still have a high amount of this highest rate in the world of centenarians. And when you look at Sardinia, very similar. So what is it then? It's not about low fat, it's about the type of fat, but it's also about the company that you keep and community, and the fact that all these people believed in a power higher than themselves. They had friends, they belonged to a community, even though some of their friends had died. When you look at the Okinawans, for instance, they hung together, they clung together, they supported each other. I happen to have been lucky enough to do some of my training in White Memorial, which is part of the Seventh-day Adventist, right? The Loma Linda. And it had a lot to do with their diet, yes, but it also had a lot to do with company again. And the fact that, they're a very integral, an integrated group, and they support each other. They meet often. They go on outings. They exercise. They drink lots of water. They eat nuts every day. And eating nuts, that's not a low fat. See, it's like you have to look at the whole picture, and fat has been devilized in the United States. And if any of you haven't read the book, The Big Fat Surprise, I would really encourage you to read it, because this author goes through how all the studies were warped by one particular person, because that person wanted us to believe what he wanted us to believe. But we really need to look at the studies, and we look at science. And sometimes when people are trying to make a point, they will vilify or they will ignore some of the information that doesn't sort of agree with them. That's called picking the data, or cherry picking the data. But I think we need to really be able to, just like you said, make sure that it really hasn't been modified. And what are we really talking about? Because I see the same thing happening. Oh, the Mediterranean diet is a really low-fat diet. No, it's not. It's the right type of fat, though. I'll get off my soapbox.
That's a very good soapbox.
You guys have great questions. Thank you.
Well, your presentation was outstanding, and it looks like we're at the end. And do you have any last-minute things to say that before we call it a day or a night?
Well, I just want to wish everyone happy holidays, and I just one more plug for living, in that fear that is so pervasive these days. And if any time that you find yourself in that, if you can just think of, what else can I go? Where else can I be? How can I change my mindset? That, I think, will do more for your immune system than anything else. Of course, it is all interconnected, right? It's all cumulative. But I see the fear in so many people's faces, even just doing it through Zoom or crossing someone on the street. And to me, that's the worst. That's our worst enemy. That's the worst thing for our immune system, whether we're talking about insulin resistance or we're talking about COVID-19. To really try and have a little bit of peace and serenity in your life will take you a long, long way. However you can do it, whether it's through meditation or prayer or looking at the ocean or taking a walk or talking to your loved ones. Just please, try to focus on having a little bit of serenity every day, and as much as you can, getting out of that fear state, because that will ruin your immune system more than anything else. And I want to thank you for the opportunity.
Appreciation and gratitude.
Absolutely, and mindfulness.
Practice.
Yes.
Susan?
Well, thank you very much. If anybody has any last minute questions, raise your hands. But thank you, Filomena, and I hope that you come back, because you just teach so many people, and you can teach us as well.
I would love to. And thank you guys for holding the fort and doing this. Kudos to you.
Absolutely. Thank you.
Brian? Oh, you just wanted to say thank you?
Yeah.
Okay.
Well,
Okay.
we start again in January with Stephen Sinatra, and then we've got Jeffrey Smith coming, and we've got some GMO researchers, and we'll see you all in the new year. If you've got any suggestions, let us know. sign up for our emails.
Good night.
Thank you. Good night, everyone.
Night.